Dr. Nancy. Hi, Dr. Maria. Welcome back. Today, we're diving into a topic that's both practical and deeply patient-centered. How we manage hypothyroidism when standard treatment doesn't quite do the job. We'll walk through the European Thyroid Association's guidance on levothyroxine, liothyronine, and when combination therapy might be considered. Sounds interesting, Dr. Nancy. I see so many patients on thyroxine who still don't feel well. I've always wondered what we can do for them. Exactly, Dr. Maria. Let's start with the basics. Levothyroxine, or LT4, is the standard treatment for primary hypothyroidism. For most patients, it restores normal TSH levels and relieves symptoms. But about 5 to 10% of patients still feel unwell. They describe fatigue, brain fog, low mood, or just that their well-being hasn't bounced back, even though their TSH is normal. That's a pretty big group, Dr. Nancy. Why does that happen if their labs look fine? There are several overlapping reasons, Dr. Maria. First, hypothyroidism is chronic, and recovery can be slow or incomplete. Second, many of these patients have other autoimmune diseases, chronic illnesses, or things like sleep disturbance, depression, or chronic pain, all of which mimic hypothyroid symptoms. Third, autoimmune thyroid disease itself may cause ongoing symptoms. And finally, and this is key, LT4 alone might not restore normal T3 levels in every tissue. The thyroid naturally secretes both T4 and T3, but when we rely only on LT4, we depend on peripheral conversion to T3, and that varies between individuals. So, Dr. Nancy, we shouldn't rely only on TSH to judge how the patient feels. Exactly, Dr. Maria. And before changing therapy, the ETA recommends a systematic approach so we don't mislabel one as having resistant hypothyroidism. What does that systematic approach include? We check the basics. Is the patient taking the medication correctly? Are there absorption issues from food, supplements, or other drugs? Was the blood test timed properly? Are there comorbidities like anemia, B12 deficiency, sleep apnea, depression, or other autoimmune conditions? Only after ruling out and treating those factors do we consider altering therapy. It keeps patients safe from unnecessary changes. Right, Dr. Nancy? Once we've ruled those out, what's next? Then we talk about combination therapy, LT4 plus LT3. The ETA is cautious. LT4 monotherapy remains the gold standard, but a trial of combination therapy can be considered in a small, carefully selected group of patients who have persistent symptoms despite everything else being right. What kind of patients are we talking about, Dr. Nancy? Those who have real ongoing symptoms, Dr. Maria, who take LT4 regularly, whose TSH is normal on an adequate dose, who've had proper counseling and support, and who still haven't improved after at least 6 months. And of course, they must understand this is experimental and needs close monitoring and shared decision-making. Got it, Dr. Nancy. So if we decide to try LT3, how do we do it safely? We try to mimic the physiological T4-T3 ratio, Dr. Maria, somewhere between 13:1 and 20:1 by weight. Usually that means slightly reducing LT4 and adding a small LT3 dose. Can you give an example, Dr. Nancy? Sure, Dr. Maria. Suppose a patient is on LT4 100 micrograms daily. We might reduce it to 88 micrograms and add LT3 at 5 micrograms twice daily. LT4 stays once a day. LT3 is split into 2 doses, one before breakfast and one later in the day because of its shorter half-life. And those combined tablets we sometimes see, Dr. Nancy, are they okay? Not if their T4-T3 ratio is below 13:1, Dr. Maria. They don't reflect physiological secretion, so the ETA doesn't recommend them. Use separate tablets instead. Let's put that into a case. Sure, Dr. Maria. Picture a 45-year-old woman on LT4 100 micrograms daily. She's still fatigued, her TSH is normal, and you've ruled out other causes. You could try LT4 88 micrograms plus LT3 5 micrograms twice daily. That's within range. Then monitor symptoms and labs closely. If things worsen, you can always revert to her original LT4 dose. That makes sense, Dr. Nancy. How long should we continue the trial before deciding? 3 months is reasonable, Dr. Maria. Check thyroid function at 6 to 8 weeks, and remember to draw blood before the morning dose. We're looking for a normal TSH, acceptable free T4 and T3 levels, and a good T4-T3 ratio. And if the labs are off, Dr. Nancy, adjust only one component at a time, preferably LT3, since it's more likely to cause side effects like palpitations or anxiety. If the patient feels better and tolerates it, continue with regular review. If not, stop LT3 and return to LT4 alone. Ideally, combination therapy should be started and monitored by a specialist. What do studies say about outcomes, Dr. Nancy? Do patients actually feel better? Clinical trials haven't shown consistent superiority over LT4 alone, Dr. Maria, but some patients report improved mood, cognition, and quality of life. Many even prefer combination therapy. So while it's not universally better, it can help a subset. And that's where shared decision-making matters. Safety must be a concern, Dr. Nancy. Yes, Dr. Maria. LT3 can cause thyrotoxic symptoms, palpitations, tremor, anxiety, and rarely atrial arrhythmias or bone loss if overreplacement occurs. Be cautious in elderly or cardiac patients, keep doses small, monitor frequently, and educate about warning signs. I've heard LT3 is also used in thyroid cancer preparation. Doctor, how does that work? Correct, Dr. Maria. In radioactive iodine therapy after total thyroidectomy, we need high TSH to help iodine uptake. To reduce the time patients spend in deep hypothyroidism, we sometimes switch from LT4 to LT3 for a few weeks, then stop LT3 for about 2 weeks. That helps TSH rise faster and makes the process more tolerable. It's a specialized protocol handled by thyroid teams. That's clever, Dr. Nancy. So LT3 has a role beyond combination therapy too. Exactly, Dr. Maria. All right, Dr. Nancy, before we close, what are the key take-home points? Number 1, Dr. Maria, always start by searching systematically for non-thyroid causes of persistent symptoms. Number 2, if after 6 months of optimal care, a patient still feels unwell despite normal TSH, consider a cautious monitored trial of LT4 plus LT3 after shared decision-making. Number 3, use separate LT4 and LT3 tablets, divide LT3 into 2 doses, and monitor labs at 6 to 8 weeks, adjusting only one component at a time. And number 4, stop the trial if there's no benefit or if side effects occur, and involve an endocrinologist for complex cases. Perfect summary, Dr. Nancy. It's a nuanced topic, but with thoughtful, patient-centered care, we can really make a difference for those who still struggle after standard treatment. Exactly, Dr. Maria. That's the goal, redefining hypothyroidism care with evidence, empathy, and good clinical sense.